Hearty good morning and sincere welcome to Renal Rehabilitation Symposium. I'm Dr. Shweta Malik, consultant occupational therapist, and it's my privilege to co-anchor this event with my dear friend, Dr. Maharaj. Thank you, Shweta. Myself, Dr. Maharaj, I'm consultant therapist. As I was suffering from bronchitis, please excuse me for any inconvenience. Before we start, just remember, the only bad workout is the ones that didn't happen. And the only bad kidney is the one that didn't get its daily dose of movement therapy. Let's begin the session. We now request Dr. Piyush Kimatkar sir to escort Dr. Rajeshri Vaishnava and occupy their seats on the dais. Dr. Rajeshri Vaishnava is an inspiring mentor for thousands of students and faculty members. She is currently serving as a Dean Faculty of Interdisciplinary Studies. Studies Head, PG Department of Education, RTM Nagpur University. Dr. Piyush Kimatkar sir is a consultant nephrologist and currently serves as President of Nephrology Society, steering the organization towards excellence in patient care and awareness. Next, we invite Dr. Dhananjay Ukharkar sir, Trustee, Ashwini Kidney Trust, to kindly take his seat. We request Dr. Pallavi Bhavik ma'am to welcome Dr. Rashtrasant ma'am and Dr. Teresa sir with chaplain. Thank you, ma'am. We now invite Dr. Rashtrasant ma'am to give her welcome speech. I request Rashtrasant ma'am to please welcome Dr. Dhananjay Ukharkar.
Respected dignitaries on the dais, and the nephrologist and medical expert, Dr. Teresa, a trustee of Ashwini Center, Dr. Piyush Kimatkar from Nephrology Society, distinguished guests, teachers, faculty members from medical category, research scholars, students. On behalf of Postgraduate Department of Education, I warmly welcome you all. This is the first time Department of Education is collaborating with the medical fraternity, because I believe medical education or the aspect of health and disease is always related with the social, psychological, and educational aspect of any individual. So when we collaborate, I just said thanks to the Nephrology Society and Ashwini Center for extending their hand to the department because with this collaboration, we will be able to promote holistic health, which is one of the very important aspects of today's human. I remember my first research, which I conducted in the year 2001, I think. That time, I was working in the interdisciplinary area with the type 1 diabetes. First time I realized the student is sitting in my class, affecting with the type 1 diabetes, having lot of problems related to diabetes. He's having short of memory, power, as well as eyesight increasing problem, or physical problem which is creating. Another very important study is that conducted in about after 50 years. With the teachers suffering with diabetes, they are also having this type of memory problem, retention problem, long-term memory, short-term memory, and we people are not aware about it. So, keeping all these things, I feel that there must be a collaboration between medical fraternity with the people of education because dissemination of information for holistic health, proper care of the patient with a proper, we can say, promotion to such type of persons who is suffering with chronic disabilities. So education, because I'm a teacher trainer, educationist working in the field for last 30 years. When Utalkar sir and Madam Ashwini came to the department, I thought, yes, I imagined before in the year 2002-3 that we should collaborate, we should work together, and we should promote a holistic health environment and with the right kind of education to the market, so they will be able to get healthy lifestyle, promote healthy lifestyle. And this is often can just remember my another research which I conducted on learning disability. Students suffering with ADHD and other kind of disability. So you won't believe that during my research, I came to know that because we as a social, we work in the psychological aspect, we work in the social aspect. What I realized that, and I just heard the take an interview from the mother to Dawn. So it was a very good question I think that from before that most of the Indian learning disability during the pregnancy period and before that the habit and the use of media is a reason for that. Because we treat directly you treat the patient with the symptoms. But the reason behind how this happens, because in the next I think 2030 will be more than 10% of the population will suffer with the learning disability. The same thing happening with the use of mobile devices. Recently, one of my students scholars is conducting a study on how these digital devices affecting the health of the individual, mental health, the social health, the psychological health, as well as the memory, reasoning power, and all these things. So I think that you all people are learning to along with that we just promote the holistic way of lifestyle, which the professor can explain you much in a better manner. But I just my recommendation to all the people and request to all the people think the why this is happening, what are the reasons this is happening, and how we can you are providing medicine, you are providing support to them, but how we can promote holistic way of living, that is also very important. So thank you so much for joining in such a big manner with us. Thank you so much. And I just say once again my thanks to Ashwini Kidney Trust and National Medical Society for giving us the opportunity to have this with us. Thank you so much.
Thank you, ma'am. Now we request Dr. Piyush Kimatkar sir to kindly address the gathering.
Hello. Yes. Good morning, everyone. Please, yes, the largest and pipeline for education welcome to you this chilly winter morning. So, there's a this is an initiative taken by PGTD party. Hello. This is a great initiative taken by the Department of Education, RTMNU, along with the Ashwini Trust and the Nephrology Society to bring on a single platform all the workforces who are dealing with the CKD and the subsequent management. So, as the madam said, it's a holistic approach that has been framed that should be made so that CKD should not be just seen as a thing of giving medicine, dialysis, transfusion. It has a more broader range of management. So, this is a major introduction for this symposium, and subsequently, other speakers will be dealing with the lecture. So, it's a long-term condition CKD, where the kidneys are damaged and can't filter blood properly, leading to waste and excess fluid built up in the body. That's a simple language to understand. Basically, when the kidney function hampers to such a degree that there are some residual metabolic or functional changes in the body, which can manifest as symptoms or some complications, that we label it as CKD. But the scientific term, next slide. It is defined as any kidney damage which occurs for and stays for a duration of more than 3 months, and the glomerular filtration falls below 60 or at 60 ml per minute per meter square, along with pathological abnormalities, other markers of kidney damage like proteinuria, blood abnormalities like rising urea, creatinine, imaging abnormalities, and also appearance of kidney transformation. This is the scientific result. Next. So, coming to the epidemiology of CKD worldwide. So, if we look at the world, an 843 million population by 2017, that is approximately 1 in 10 of common people were suffering from this, whether known or whether unknown. And commonly, individuals with diabetes, hypertension, women, elderly, racial minorities, they find more prevalence in this. If we look at the rising graph, in which it stood as the 12th common disease in 2017, and would be heading towards the 5th rank by 2014. So, such is an impact of this, which needs to be addressed. It has a large burden in low and middle income countries, and among the top 10 causes of death in Singapore, Greece, and Israel. Next, please. Coming to the national burden. So, the full prevalence of CKD in India, so it was earlier around 10 to 11%, and now it has risen to 16.4% as per the recent scientific data. So, the prevalence is higher among men as compared to women. And the southern administrative zones has shown a prevalence of more common in the rural areas. Next one. So, this graph where the dark regions are shown, they are showing the chronic disease percent of more than 24%, in which Maharashtra and the southern states are seen. And the green and red regions are the rural and urban regions. Major causes I had discussed like diabetes, hypertension, along with this chronic glomerular nephritis, any obstructive components in the urinary tract, and various drug-induced and other nephropathies are common. So, why CKD matters to us? So, CKD is not only a disease, but it's a social burden, family burden, community burden, social burden as well. So, it's a progressive, often irreversible disease, has a high cardiovascular mortality and morbidity, major contributor to catastrophic death expenditure, but potentially preventable with early detection and risk factor. Next. Impact of patients on patients and health system. High out-of-pocket healthcare expenditure, loss of productivity, reduced quality of life, dialysis dependency with increased psychosocial stress, and increased hospitalization and mortality. So ultimately, moving our shift of paradigm from disease management to the lifestyle restoration. The concept came as renal rehabilitation, with the traditional CKD where it focuses more on pharmacotherapy, dialysis, transplantation, and perhaps neglecting physical conditioning, mental health, and lifestyle support. And the renal rehabilitation has become also complete of the holistic treatment method. I leave the further platform for the other speakers to have a further comment on and knowledge.
It is more in Maharashtra and Southeast state. So what could be the reason for specific?
So, these southern parts, the parts of Maharashtra, we are coming up with a burning issue of CKD unknown origin, CKD of unspecified origin. I have already pointed out the important etiology, but the CKD is determined as a second or third leading cause of CKD, nationwide and also worldwide. In which the etiology is not known exactly, but there is also a lot of contribution to the CKD project. So, which possibly increase the fluoride cadmium levels in the soil use, pesticides, fertilizers, such communities, and where there is high hot climate with some even farmers with who are farming sugar cane. So, these have been attributable factors in which CKDU has emerged as a growing health condition in such society. So southern and particularly Maharashtra has shown a higher incidence. Monali madam and Professor, they have more experience in this. Possibly,
use of herbal products which are unregulated. Then pregnancy detected acute kidney injury leading to CKD. So pregnancy related complications which go unnoticed. Ladies suffer from this maybe AKI, going into CKD. There are multiple causes. Traditionally heat stress. These farmers who are working in hot climate, not drinking good water from the body. Agrochemical exposure. Cases I already said. Say that these things are more in Maharashtra and southern part. That is what we must say. So why these people are suffering?
Thank you, Mr. Head, for your valuable input. As Jim Rohn said, take care of your body. This is the only place you have to be. Today, we take the step forward in renal rehabilitation. We invite our chairperson, renowned nephrologist, Dr. Monali Sharma, and Dr. Preeti George, physiotherapist. Now I request Dr. Monali Sharma and Dr. Preeti George to kindly grace the dais. Dr. Monali Sharma is a consultant nephrologist at Medas Multi-Specialty Hospital. Dr. Monali is known for her extraordinary ability to make even the most complex concept of nephrology sound simple and interesting. She is truly a star of nephrology in Central India. Dr. Preeti George is a physiotherapist. She is a board certified orthopedic clinical specialist. Dr. George was appointed by the government of Nigeria to serve the Vikent Board of Physical Therapy. Now I request Dr. Rakhi Gadkari to welcome Dr. Monali Shah and Dr. Preeti Bojma with the charting and a certificate of appreciation. Over to you, Chairperson, to introduce Dr. Upalkar and make opening remarks. So, very good morning to everyone, and we are really excited to be here. As usual, Upalkar sir has proven to be innovative always. He has lots of innovations to his credit. I will tell you in his introduction. But we are extremely happy as a society of nephrology to be involved with you all, the need of the other, which is really important when it comes to treating a patient of chronic kidney disease. Because chronic kidney disease does not affect only kidneys. It is a multi-system involvement involving bones, musculoskeletal system, heart. Cardiac risk is more for these patients. Then they are on dialysis. They are losing their job opportunities, or the job opportunities become less for them because of the requirement of dialysis, or they go on transplant. So at every point, there is a need of physiotherapy, occupational therapy, which should start from the very beginning. As soon as the disease becomes advanced or maybe goes to stage 3 or 4, we will listen from the culture what it is and how it can be incorporated in the management. So this is really important for every one of us. So now coming to Professor's introduction. So this is a big task given to me actually to introduce Professor Sir, who is one of the leading nephrologists from Central India, and he received his training in nephrology from KEM Hospital, Mumbai, and that was done under one of the notable the nephrologist Vn Acharya Madam, and then he also worked with another prominent nephrologist from India, Dr. Rashtrasant and Sir. He had excellent academic career of more than 30 years in the field of nephrology. He has really practiced tackling patients of renal diseases from all over Central India and maybe even more from around India. He is an experienced organizer of professional societies, and he has a keen interest in clinical research, bringing research to solve day-to-day problems in clinical practice. His publication on quality improvement in healthcare using FMEA's tool for infection control in hemodialysis was published in International Journal of Quality and Reliability Management in 2009. He is author of 2 chapters, Anticoagulation in Hemodialysis and Personnel in Hemodialysis, of Indian Guidelines of Hemodialysis, released by Indian Society of Nephrology. Then he has also
These guidelines were published in Clinical Establishment Act of Government of India, 2020, and he is also editor and author of Hemodialysis Handbook for Technicians. And this was published in 2014. Another important thing that sir has done is founding the Dialysis Technician Assistant Certificate course by RTMNU Nagpur University through Central India Nephrology Society and Bhaiyaji Pandey National College of Social Science. And also he is founder of Certificate course for Dialysis Technician conducted by Akaria Institute of Vocal Studies under Maharashtra State Board of Technical Education Vocational Board. So these are very important things if you will understand that you saw the number of kidney patients which are happening. Subsequently, those who are going into advanced kidney failure requiring dialysis. So huge number of workload is there of the patients who are on hemodialysis. So for hemodialysis, we need hemodialysis technicians. And this need of technician has always been tackled because of only very actively or efficiently, because Upekar sir from his institute has been providing technicians since long time, and then he made it a point that these technicians are well trained. So we are really thankful to him that so many technicians working around in central India. Maybe you will find that majority are from they have worked in APDC, Ashwini dialysis. So that is an important achievement also by sir. And so currently he is pursuing his research on chronic kidney disease of unknown etiology in Vedanta. So we are really happy to have sir and his initiative. Thank you.
I realized that was not a very good model. We allowed the patients to work, and then we find we have to treat the patients and work, like giving them a discount. So I thought that let's try and see whether we can be better. And one model is to rehabilitate the patient from the beginning. From the time when the beginning starts showing signs of weakness, to the time when the completely going down and the patients are lying on dialysis, that is rehabilitation. But then why is there a need for rehabilitation? Because conventional wisdom will tell you that this is the way, so we need to know what to do. The electrolyte balance, what do you do about the so that is the last. Because the changes in CT are certainly not the changes. What happens? One is the change. And this is what I'm going to talk about today. My objective is fivefold. I want to talk about what happens to the muscles in the patient with CKD. What happens to the bone health in CKD? How does weight affect CKD? And what happens to the mind, the emotions in CKD? And the most neglected, but unfortunately the most prevalent problem with the patient with chronic disease, which we will have, is pain. Pain is the consistent feature of their life for 24 hours. Unfortunately, pain is the most neglected because pain, unfortunately, is associated with painkillers. And everybody knows the speed also, and now with painkillers, you are patient with
requirement. So what do you know? The people's quality of life is such a tremendous load that they're just carrying on the burden of this body to life. It's like so. This is not surprising that chronic kidney disease involves all aspects. It impacts his social life, it impacts his emotional and mental health, it impacts the social and economic aspects of his life. And the physical health impacts which commonly studied and we have a medicine is the cardiovascular problem, for which you have lipid lowering agents and there are pharmaceutical industry behind pushing the lipid lowering agent, making us believe that you put a patient a lipid lowering agent and your job is done. The fluid and electrolyte imbalances have pharmaceutical industry background because if you are patient an diabetic and you believe that swimming is not, patient also believes that the disease is capital. There are beacon bones, you give a phosphate lowering agent, and the medicine is there, the pharma is there. And then you can immune system, you have antibiotics, you have depression, you have an antidepressant, you have treatment, you have no medicine. Where the life becomes burden and it is constant family conflict. So nobody talks. And concentration, the patient with chronic kidney disease can focus, there is no medicine that will adapt to the The socio-economic aspect, there are absolutely no medicines there. If somebody loses a job, he loses a job. He's stressed out because of loss of job, there is no pharmaceutical agency behind this, so nobody bothers to look at it. But let us focus first on things which we can tackle somewhat, and which is beyond the kidney. Is the muscle. The muscles atrophy. And this is a slide which will show you on A panel there is a normal muscle. On B, the muscle is infiltrated by fat, and the muscle becomes small. So this is a pathology that as compared to muscle area, the strength of the muscles also reduces. So not only do we have atrophy, but the contractive power of the muscle is also reduced. And it is multidimensional. You have protein energy malnutrition, you have frailty, you have aging, because majority of the patients with chronic kidney disease that you will see today are people beyond the age of 50. Beyond the age of 40, the muscle mass itself starts to decline. So on top of that, when you have additional problem of chronic kidney disease, it will not surprise you that these people are really muscles. And this will start happening here. It's affecting about 13.7 to 42% of dialysis patients, but it is the progressive muscle mass as well as strength. And the muscles are the source of protein in the body. So whenever you have a progressive muscle mass, somebody might think there are just need to measure the lung muscle allow them to do a diagnosis of sarcopenia. This half of people. Because for 30% of people who have sarcopenia have normal muscle growth. So you need to look at muscle strength in some other way. Because it leads to no muscle strength, no muscle quantity or quality, and no physical performance. So if you have one criteria, possibly sarcopenia, if you have two confirmed, and you have all the three, you have severe sarcopenia. Sarcopenic obesity happens in about 13%. Patients are well built, they seem to be well built, obese, but they have low muscle strength. And as the speaking of progresses from early stage to late stage, the prevalence of sarcopenia also increases. This is how we diagnose sarcopenia in the clinic. It's very simple, very clinical. You measure the speed at which this person is walking. Is he walking more than 0.8 meters per second, then you perform a hand grip test. The next slide we show you how we do the US, all of you are aware of it. And then you classify the patient, everything start to be down on the. If the speed is less than 0.8 meters per second, you would have to do a scan, and then below above the threshold, you would have to classify the patient as no muscle mass experience. Because of these muscles changes in CKD, the clinical consequences are functional impairment. You could go the other way, look at functional impairment and then take a diagnosis of muscle change, loss of independence, loss of ability, activities of day. There is a 3 to 4-fold higher risk of falls in these patients, leading to fractures. And low hand grip protects mortality, independent of muscle mass. In fact, the very simple test which all the patient can do is to just shake the hand of the patient. If the hand grip is weak, then you can prognosticate that death is imminent within 6 months of time. And the strength decline precedes legitimate muscle weakness. So the patient may not have a subaltern great triceps, your normal biceps. But the strength of this growth means the next stage of loss of muscle mass. So this is the hand grip strength. I believe just as a recently known the hand grip assessment is essentials and let's see how it is done. It's very simple. We measure every patient's hand grip and then the classification. This is an independent predictor of all-cause mortality in dialysis patients, and there are different cutoffs in the population. Regarding the cutoffs which are not the Chinese, I believe there is a scope for research in the Indian population and having our own. And muscle loss is dangerous because muscle loss leads to risk of hospitalization. The more the muscle loss, the more the risk of hospitalization. We want to go to the other basis of muscle loss, muscle disability, but basically there is more catabolism than anabolism. The second objective is to bone health, and we realize that patients who have advanced renal impairment have increased 5 times increased fracture risk as compared to the general population. Hip fractures 4 times higher incidence than in the general population. We are seeing in dialysis patients. Often ignored and missed out on the vertebral fractures. Less than 18% prevalence in stage 3 to 5, and vertebral fractures is 26% mortality. And next slide, please. This again, the changes which are decreased CKD patients of reduction of serum calcium, increase phosphorus, increase pH, and reduce 135 dioxin. And there are various physiological changes which occur in the bones. But bone fragility factors are very common in these patients. And physiology is often underutilized. X-ray arm, or palm would help us in getting adoption, osteoporosis. Now, all does it lead to weakened bone, weakened muscle, leads to frailty, and can go multiple quadrants. It is characterized by diminished strength, endurance, and reduced physiological function. And this leads to increased vulnerability. And frailty increases as renal function improves, and patients plan on dialysis. And this is a tool to measure severity, which uses weight loss, exhaustion, physical activity, fortified with medicine. Very simple, bedside, clinical parameters on which we can make this very important diagnosis. Falls are common. 19% of them will require medical attention. And I was surprised that 7% of these patients will develop some maybe 4% will have fractures. And the fear of falling will prevent this person from moving about, leading to social isolation. The factors are multiple. Neuropathy, muscle weakness is the most important, and orthostatic hypotension because of the disease as well as because of the medications given for the disease to control the blood pressure. And many people, unfortunately, have only one blood pressure reading, that is line blood pressure reading, and the blood pressure is changed in case of pregnancy. And unfortunately, what is happening is his blood pressure in the random condition is low, is high, he gets up, he goes down, and then medications he cannot control. The same medicine is given, this postal hypertension will go. Balance is also there. As the disease progresses, checking the balance will be very important. Again, a simple website like this. We have exercise tolerance is being used as CKD progresses. Next one. And then there are forms. Next. And because of this fear of all these patients are sitting, and as kidney disease increases, this percentage of people who are sedentary, that is less than 2,000 steps a day, increases precipitously. And what this does is, it leads to worsening of the control of diabetes, hypertension, it leads to depression and disability. And the main problem is muscle mass loss. Surface cells reduce inequity decreases survival rate for diabetes patients. So much is at stake, and so much can be done. What are the interventions and investigations? Unfortunately, is that symposium is to sensitize ourselves to what we can do and achieve. Next. It leads to depression and anxiety. The two very important things which result in this population cases are very good mental. And depression in dialysis population can reach up to 40% or 30.5%. This has implications like therapeutic compliance, treatment adherence, and then poor adherence leads to a worse outcome leading to this distress of patients. It also leads to social isolation and activity elements. So, we have been talking about patients, but what happens to the caregiver is often a neglected issue. But the caregiver also has to do this burden, and after some time, she goes into the burnout. So, we need to tackle that. If we are seeing the patient, the patient need not be only focused upon the attention. The family members should also be. Pain is another more common problem in patients with chronic kidney disease. And the prevalence is up to 60%. Various kinds of pains which you know better than me. You do not talk about these things. Next slide. And as the disease progresses, and certainly even at the beginning of the disease, the pain is a predominant problem with the patient. Right? Next slide. So there is a very strong impact of pain on the overall quality of life, and we might monitor patients based on their diabetes, their anxiety, their PGTD. But actually, what is happening to that person is living. It will become a very important parameter to monitor, unfortunately. Disease in fact, these incorporated in patient care. I believe we will be able to give a better holistic care to our patients. Thank you.
Why you are
this is generic advice. If you want to protect your kidneys, have more water. But when kidneys fail, the water starts circulating in the body. So this will become inappropriate advice after the kidney starts failure.
Next person in the introduction.
One thing what I but something
If put it right, some of them are doing it. That is not the very effective way of running this in the body. So the amount of weight loss and also how much they are going to achieve because of doing this.
To do that much exercise. Cardiac has support like exercise to have significant sweating to have water loss or fluid loss.
not thinking only walking other cardiac because we are not expecting like already.
There are some people that she's baby. I don't know, I'm not aware of any scientific literature. They have evaluated scientifically which class of patients does it work, how much does it work, using crucial questions to answer. Thank you.
Thank you, Dr. Tucker, for that great presentation and linking how chronic kidney disease affects the musculoskeletal system, which I think occupational therapists and physical therapists are well positioned to address that. I would also like to thank Dr. Tucker and Madam for the kind invitation and having me. It is such a privilege to be here and to listen to all of you. So thank you again. I would also like to point out a couple of things in your presentation which kind of hit the home run for me. As you mentioned about the pain, movement is the greatest pain reliever. So if we look at it those lenses, we can address pain through movements, and I think that's a very powerful tool which we can empower our patients with, along with the medication which we can provide. But movement gives not only the confidence and empowerment, but also the pain relief which we want. The other thing that you mentioned about fragility and how it leads to gait disturbances and the decrease in gait speed. We call gait speed as another vital sign, because as we see the gait speed slowing down, we know that the general health of the patient is going down. So we can kind of really capture that vital sign and kind of start addressing the physical needs of the patient. The other thing with the fragility comes the falls. And we know that once the fall hits, the patient hits the ground, they have a fracture in the hip, we know that life expectancy is significantly reduced. So all these aspects, early referral is really mandated for physical and occupational therapists. And I think this symposium is a great way, a great segue for that. So early referral to rehabilitation in any condition, like from acute, subacute to a chronic kidney disease. I think the rehabilitation can play a role in moving into recovery. So thank you all very much. That's been a great honor.
Thank you very much, sir. Tukadoji sir has sensitized us for incorporating PET tools into CKD management from very beginning before they go in for advanced problems. So preventing them by the use of tools which are bedside and incorporating into clinical practice is something really worth noting and now working upon. Thank you very much, sir. And
inviting us here. Again, and thank you for inviting us for inviting us as their person for this opportunity.
Thank you, sir. You have motivated motivation and assistance for us to bring the inaugural session. We request that person to present the samples to Dr. Rashtrasant. For the next segment, we invite Dr. Ashwini and Dr. Maharaj to carry out presentations. And had an excellent of learning. Rajans studied senior physiotherapists and president of Indian Association of Physiotherapists. And Dr. Teresa takes to welcome Dr. Ashwini and Rajans studied staff. Chairperson, please take over the proceedings and introduce Dr. Maharaj.
Good morning, everyone. It gives me a great pleasure to introduce our esteemed speaker for this session, Dr. Damke Madam. Dr. Damke Madam is a principal and professor of physiotherapy at Government Medical College, Nagpur, and is associated with the Maharashtra State Health and Healthcare Council, contributing actively to the advancement of allied health education and professional standards. She is a distinguished alumni of GMC Physiotherapy, 1987 batch, and completed her postgraduate training from LTM Sion Hospital, Mumbai, from 1991 batch. She also holds a PhD in Health Profession Education from the Tamil Institute of Medical Sciences under the guidance of Honorable Rashtrasant. She has received multiple award-winning papers at national and international conferences, has served as a faculty at numerous academic forums, and has been honored by the government of Maharashtra and the national bodies for her exceptional work in physiotherapy and rehabilitation of women. Her notable and inspiring contribution includes the physiotherapy rehabilitation of two paralyzed leopards, reflecting her innovative and compassionate approach to rehabilitation science. We look forward to her insights on renal rehabilitation, a vital and evolving component of holistic nephrology care. And on the behalf of the Nephrology Society, I warmly invite Dr. Damke to deliver her talk.
A very warm good morning to our most respected teachers, the way Teresa and our chairpersons, Sanjay and Dr. Harshad, Himankar sir, Madam, and all dear colleagues. And of course, Sophia, ma'am, and Kavya. I will, if I take the names, I have to take the names of all, and of course, yes, PD. Before I would start my lecture, I would just want to take 2 minutes if you permit me. Sir has said that about sir has taken out this dialysis technician's post, right, sir? And being now the chairperson of Allied and Healthcare Council, I would just want to put up one very important aspect. The other day when I had met the Honorable Secretary Medical Education, and we were discussing about the Allied and Healthcare courses and about all the important points about it, sir. So I had a question like, मैडम Allied and Healthcare अभी चालू हुआ है, तो अब तक इन लोग कौन से काउंसिल के अंदर में रजिस्टर्ड हुए? I was saying sir they had never been registered under anything. So मैडम क्या आप ये कहना चाह रहे हो कि मैं किसी डायलिसिस के लिए किसी हॉस्पिटल जा रहा हूँ और वो जो टेक्नीशियन मुझे डायलिसिस दे रहा है, he is not accountable. He is not accountable by law. No one knows what is his graduation level. Is he a graduate? Is he even legal or illegal? Are his studies legal or illegal? Oh my God. And am I representing office? Was the question of secretary. So now, when Maharaj said that sir has really been into all the enrollments of the dialysis technicians, we definitely need to talk after this quite a lot. And definitely a big hand of applause for because very important aspect and मुझे लगता है कि as a dialysis person मला असं वाटतं की सरांनी जे काही त्यांना फक्त नॉलेजच नाही दिलं पण त्यांना कंपॅशन जे पेशंट बद्दल शिकवलं. That is an important aspect. Coming back to now, role of physiotherapy in renal rehabilitation. सरांनी already भरपूर why it is important. Rehabilitation is important in kidney. Sir already बोललेले आहेत. I speak in Marathi. And is that okay in English? Because आजकाल खूप जास्त मराठी होतंय, so sir, being government, everything is in Marathi. Next slide, please. So, what is renal disease due to physical care? Sir has spoken about the kidney aspect. I would like to speak about from physical function point of view, right? So, as sir has said, muscle wasting and weakness. Muscle wasting and weakness, point number one. The moment the patient gets diagnosed with CKD, we know he is already swollen. With so much of a weight, is he able to walk? No. Right? It's difficult for us to walk with so much of a weight. So, अगर मुझे यहाँ से पानी लेने किचन में जाना है, so the first thing that if the patient is a mother or a father or a grandmother or a grandfather, the son will say, "Mama, रुको मैं लेता." Decrease in physical activity, right? Muscle wasting and weakness just does not come because of uremia. It also comes because of inactivity. So, very important, the physical function which decreases is not only the pathology, but also the reduced functional capacity, which has also come because of a reduced physical activity. And reduced physical activity is not that the patient cannot do it, but we, as his caregivers, his or her caregivers, prevent the patient from doing it. This is a very, very important aspect which we need to look in. So I'm not only going to speak about the scientific approach, but also more of a psychological aspect to the physical health. And that then leads to physical deconditioning because the patient has not been walking too much. Everything is getting onto his bed, and this leads to a physical deconditioning. Next. So, a reduced physical capacity is one of the causes. What happens is the patient has, when I am going from here to the door, my heart rate would minimally increase by 2 with respect to a CKD patient, right? But if I'm not going to the door, I'm getting the water here itself, then that even 2 increase of the heart rate by 2 heart rates has not occurred. Thereby the heart's activity has got limited. The heart's activity has got limited, right? So no requirement of blood, the muscles have not got activated. When the muscles have not got activated, no requirement of blood, no requirement of blood, staticity of the blood, staticity of the blood, staticity of the interstitial space. Very, very important aspect, and that is what we need to work on. This staticity of fluid into our circulatory system or onto the interstitial spaces is one of the important aspects, because patients, अगर हम वहां तक भी नहीं, we will give a lot of exercises. We will give him quadriceps strengthening. We will give number of exercises sitting onto the bed. क्योंकि patient वहां तक चल नहीं सकता. But the patient doesn't take the trouble to go there. When we stand and go there, it is the gravity which is assisting. It is the gravity which the muscles have to work against. And this gravity is one of the very, very important aspects for muscle rehabilitation and for the prevention of hypertension. Unless and until we are asking the patient to walk, the physical capacity of the patient will not be retained. So retaining of the physical capacity is a very, very important aspect. So the first thing that which we have to tell the patient's relatives is, let the patient be independent. Let the patient be independent. हमें ज़्यादा patient का लाड नहीं करना. The patient is normal. This has to be taught to the patient's relatives, which is, I think, so as a physio or as an occupational therapist, a very important aspect of our training. Of course, the patient has fatigue and exercise intolerance. Anemia है patient को, he or she has cardiovascular dysfunction, right? We have 2 assessments coming up after this lecture. So they will be telling you, Shilpa and Pratya will be telling you as to what assessments you need to do and based on those assessments, what physiotherapy are we going to do. But before that, the fatigue and exercise intolerance, we have to develop 2 aspects. Fatigue. Is the patient fatigued while just sitting? Is the patient fatigued by sitting up? Is the patient fatigued by standing up? Or is the patient fatigued by just walking through the door? These activities of daily living, which level is he fatigued? ये हमको, I think so, as a physician, बहुत important है. क्यों? क्योंकि अगर आज हमारा level, for example, from going here till the door, this is my activity and beyond that is my fatigue, then the retaining of this level of exercise tolerance is the responsibility of the physician and the occupational therapist. Isn't it? So, physical function, when we look at the physical function, the fatigue and exercise intolerance is one of the most important aspects. That which we need to look, or that which happens in a renal disease. Cardiovascular complications. I would say 2. Cardiovascular complications, number 1, hypotension, number 2, hypertension. So what are we dealing with? Are we dealing with hypertension or are we dealing with hypotension? Hypertension the patient already has, but as sir has said, with the drugs, okay, and with whatever drugs we are giving him, diuretics, the patient lands up into hypotension. When the patient lands up into hypotension, it's very necessary that we progress at a very gradual pace. Not the way we come to a patient. And we know that he goes and walks to the door. Yesterday he had got up and went to the door. That is his activity. But every day when we come, what is important is we go and handle this patient a bit more gradually. First, lying down, turning, wait, sit up, wait, stand up, wait, take 2 steps, wait, and then letting do all the activities. This is how the emotional organization is going to be taken care of. So everything that which we are going to do is going to be very gradual as compared to any of the other patients. For example, when we're looking at a patient who is, let us say, a normal hip fracture patient, a normal upper extremity hip fracture patient, any orthopedic patient for that matter. We don't have to look into all this. We say, okay, chalo, theek hai, tum yahan se wahan pe chal. By the time we are doing some other assessments, what about him? But for this patient, it is very mandatory that everything has to be a gradual basis. Another aspect, looking at this cardiovascular thing, I am quite sure Shilpa will be covering up with this, but most important is before we start with the activity, at rest RPE, most important. If at rest his RPE is very light, then we can think of if at rest itself his RPE is, let us say, quite high, then I think so then that day that patient needs to be kept alone. We may come in the evening, we may consult the CKD, we may consult the physician as to today we cannot deliver any of the exercises. So judgmental at every day about this patient's health with respect to his cardiovascular conditions is an important aspect of what a physiotherapist should look at. And of course, all this leads to a decreased quality of life. Decreased quality of life, the patient is walking less, the patient is fatigued, the patient's blood pressure is high, the patient is on so many drugs. When the patient is on so many drugs, of course, there is next. There is, with so many drugs, the patient also has lots of psychological problems, isn't it? If you have to take 14 or 15 drugs per day, morning, afternoon, evening, the patient is under a lot of stress. And I think so that is when a physio or an occupational therapist, because we stay for a longer time with the patient, along with the therapy, TLC, what I call it, tender loving care, helps the patient to deal with his psychological depression or to deal with his psychological instability in a more better way when we are talking to him by giving the treatment, that which we call as tender loving care. So another important physical function that which is affected in these patients is joint stiffness and pain, peripheral neuropathy and balance problems, postural abnormalities because the patient is completely sitting all the time lying down. So a sitting posture the patient assumes when all the joints remain into open back position so that it assumes a completely comfortable position and thereby reduced independence in activities of daily living. Right? Next. So what does physiotherapy do? Improves functional ability. Improves functional ability how? The patient, let us see the patient ko chala rahe hain. What's the difference between them and us? This is very, very important. The dose of exercise is what we decide, isn't it? How much? When? Is it all of it to be given just now? Or has it to be given divided into short activities throughout the day? If the patient is a higher fatigue, then I will not ask him यहाँ से दरवाजे तक चल. I will say यहाँ से सिर्फ टेबल तक चल. But ये activity of हर 1 घंटे में करो. So what happens is The dose of your exercise is very important aspect into a patient of CPD. So this helps us improve the functional ability scientifically. Prevents complications. For example, when we are making the patient walk, when we are making the patient do exercises, stretching automatically is happening, strengthening automatically is happening when he is walking with the body weights, prevents complications, right? Complications of tightness, prevents complications of sarcopenia, prevents complications of increased cardiovascular instability because now the cardiac is getting worked out and your health is trying to become more stable. It enhances overall well-being and promotes psychological well-being. Next. So what are the goals of physiotherapy? Improve muscle strength and endurance. हर एक पेशेंट को muscle strength and endurance देते हैं. What's the difference? There has to be some difference in the patient of CPD. As far as the muscle strength is concerned, we will not give resistance, high grade resistance. The resistance has to start from a low grade. Why it has to start from a low grade? Because any strength training that which we are giving, okay, needs lots of force when we are giving. For example, if we are working at the lower extremity, these are the large muscle groups. So when we are giving a resistance training, okay, that will cause a pressure overload onto the cardiac, and the pressure overload onto the cardiac will not be taken by the cardiac because the cardiac is already affected. So it is not as simple as treating an orthopedic patient. So for improving of muscle strength and endurance, whatever resistance training which we are given, it is very necessary that we look at the RPEs of the patient, how many repetitions per maximum. So we first start with what we would say is just 3 exercises, and then go on to gradual increase in the strength. So first 3 exercises going on with gentle resistance. Rather, I would prefer more of body weight exercises. Body weight exercises like yoga, functional exercises, so the patient is independent. I again advocate more of functional activities. If we have to strengthen the quadriceps, okay, then not only just doing none of the activities we do just sitting and extending. I mean, I don't remember any activities in our daily life where we just sit and do extension of the knee. But what we do is we do a hip flexion knee extension while walking, right? So what we would prefer is giving the patient a ball to kick. That is more of a functional activity. We would give more PNF activities to the patient. So resistance into a PNF pattern is going to be much better than giving him just strengthening exercises to the quadriceps, to the hamstrings, to the calf, or to the any of the muscle. So that's what is my take when we look at, because here we are exercising 3 to 4 muscle groups at the same time. Number 1. Number 2, we are giving him activity-based strengthening. So it is the activity which is strengthened and not the muscle. Isn't that more better? So any muscle improvement in muscle strength and endurance should be more of functional activities rather than just the individual muscle strength. Increase cardiovascular fitness. Whenever we are looking at cardiovascular fitness, another important aspect that which we would like to see is the VO2 max. Right? How much is the VO2 max of this patient? And whenever we are looking at the VO2 max of this patient, number 1 aspect is the patient is already overloaded with food. So normally, if I have to walk with a 60 kg of weight, this patient is walking with 70 kg of weight. This patient is walking with 70 kg of weight. His VO2 max is already going to be less. So his maximum oxygen uptake. Okay. when they are activated, after the consideration his resting heart rate, which his resting heart rate is also going to get affected with his hypertension, with his CKD drugs which he is taking for hypertension, and thereby the VO2 max of this patient should be calculated not only by the formula, but by a proper machine, by a proper VO2 max machine. Because whenever patient is on beta blocker, the heart rate will not increase, the resting heart rate will be lesser, and the amount of activity that which we are giving to the patient, the heart rate will not reflect or will not show the amount of activity which is being put up onto the heart. So in this case, rather than looking at the heart rate, we would look at the RPE scale, rating of positive exertion scale. Is the patient getting more exerted? Because the heart rate onto a beta blocker does not rise equivalent to the amount of activity which we are giving to the patient. So this important aspect is very important whenever we are giving cardiovascular fitness, which is one of our goals of physiotherapy. Maintain or improve joint mobility. Normal regular exercises. Most important is a two joint stretching. On the normal flexion extension करेंगे उनका. But then what about the hands? What about the rectus femoris? So rather than just giving one joint mobilization, or when that is why I said functional activity is a better exercise than one joint muscle strengthening, because when we are giving a two joint, when we are giving a functional activity, it is not only causing a strengthening, but it is also causing the stretching of the opposite muscle. So emphasizing more on exercises which are exercising more muscle groups rather than individual muscle groups, that will also require less time for this patient, less fatigue for this patient, because this patient has a lot of fatigue issues. So all those activities we need to incorporate onto major muscle group activities, so that patient endurance will be taken care of. Decrease pain. Now, when we look at the pain, first it is very necessary that we analyze the pain. I would want Shilpa to look into it when we speak about the assessment. I'll take 1 minute for this pain. Whenever the patient has pain, first one, is he having overall generalized pain? Is there any tenderness? If he is having any tenderness, is there any jerk sign, like the moment he press and he jerks? Is he having neuropathic pain? Or is he having pain on activity? So assessment of the pain before we treat the pain is one of the very, very important aspects for this patient. A number of times patient just has an OME because he has been just lying down for, let us say, around a month. He has been just lying down and he has joint pain, knee osteoarthritis, and we are treating him with painkillers. We just assess the knee and give him local exercise, the knee exercises, just the static quadriceps, just the strengthening of the quadriceps, just analysis on the hams. If the hams is tight, it will lead to knee pain. If the rectus is tight, it will lead to knee pain. If the calf is tight, it will lead to knee pain, isn't it? So first and most important is assessing the cause of the pain and then treating. Not just treating pain से आया है patient, knee में pain है, हमने diathermy लगा दिया या हमने ultrasound लगा दिया या हमने no. Assessment of the pain, whether it is contractile, non-contractile, whether it is neuropathic pain, whether it is a pain which is whole of the thigh. If you get a pain which is whole of the thigh anteriorly, posteriorly, then this pain is because of the what we can say complete fluid collection, right? So the interstitial spaces are completely filled up, and thereby the patient is having generalized pain around complete thigh.
isn't it? So then we need to talk to the physician, okay, and the nephrologist. Talk to him whether we can really work out onto the movement of the fluid. How do we work out the movement of the fluid? Are there any drugs which can help him out? In this case, like for the like when we give any of the diuretics also, we can help out. So it's very necessary to assess the pain and then treat the pain. So all the exercises will prevent muscle wasting, joint stiffness, which will promote functional independence and enhance the quality of life and psychological. Improved balance and coordination is also one of the most important aspects. Simple thing. The patient is not getting up. The patient is not walking. Even if the patient is walking, we normally do not, even at this age, we have a number of falls. Recently, last month, I had 3 falls, and then I was very worried. I went to the neurologist and I was like, my God, what has happened? Then I analyzed and I said, no, I have to take myself off. Being a physio doesn't look good. I analyzed myself and then I realized why I am falling so much. Then I devised my own physiotherapy, own exercise. And most important, we do always exercises forward walking. Do any one of us do backward walking as an exercise? Isn't it? Backward walking is one of a very, very important exercise because that strengthens the body. The hands, which is a very important aspect, that strengthens the glutes, which is very important, but because that is the most important muscle to do that for. So backward walking, not only that, sideways walking. Very, very important aspect. Along with that, we always use PNF techniques to prevent falls. PNF techniques go across, go across, go across. So cross walking is another important aspect. Tandem walking, 1 foot above the. These are just very simple, very simplest of exercises which you tell your patients will help them prevent fall, and then not only to the CKD patients but in general as well, which will improve the balance and the coordination of the patients. So the most important goals of physiotherapy will be to prevent complications such as osteoporosis, contractures, pressure sores, falls, and usually if a patient is lying down for a longer time as compared to sitting or standing, the pressure sources are not a very important aspect because as we said, interstitial fluid ज़्यादा होता है, patient में तो pressure source का chances भी ज़्यादा होता है. इसीलिए हमेशा patient को bone line भी डालना जरूरी है. Bone line कम से कम जिस दिन से patient CKD से diagnosed हुआ है, most important is asking him to do bone line every 2 hours will reduce the risk of pressure source. Sorry to interrupt. Yeah. How many slides more? Okay, what? Just move ahead with it because I have covered quite a lot of it during this only. So we'll go to physiotherapy interventions. Next. So in physiotherapy interventions, exercise therapy, as we said, cycling को हम लोग हमारे patients usually कम ही करते हैं. More of walking, treadmill भी कम ही करते हैं हम लोग जिस type के patients हमारे पास में आते हैं. But when the patient is doing treadmill 3 to 5 days per week, is any aerobic exercises 3 to 5 days per week is very important. And to a patient of CKD, what is important again is, as I said, whenever we are speaking about 3 to 5 days per week, how many sessions per week? If the patient is onto a greater, the impairment is greater, short exercises throughout the day. After every 2 hours, if the impairment is lesser, then we can do only 2 sessions with more time for the patient by doing 1 session of exercise. Next. Strength training, as we said, body weights, yoga. We have already spoken on this. Next. Flexibility exercises, as we have said, when we are doing PNF, it will be more of stretching to whole of the muscle groups as an activity.
So functional activities are more important with respect to flexibility exercises. Next. So balance and functional training reduces risk of fall, improves the confidence of the patient. Very important. Improves independence of the patient because the less fear of fall, the more the patient will be independent, and it will also improve the patient's participation in daily activities. Next. Pain management, we have already spoken. Respiratory physiotherapy is an important aspect of CKD patient. So deep breathing exercises, segmental breathing, thoracic expansion exercises, and if nothing, if the patient is not doing anything, सिर्फ उसको mute play करने को बोलते हैं. जो भी any activity which makes some sound would be a good respiratory exercise. और कुछ नहीं तो गाना ही गाने को बोलिए ताकि जो भी वो response if we tell him do breathing exercises से कुछ से exercises करा रहे हैं. So we have to find out ways to how to get things done which are important, but he will not do it as an exercise. So maybe he shouts, किसी के ऊपर चिल्ला ही दे. Important, very very important, because that needs the respiratory capacity. So even if that the patient is doing one certain respiratory capacity is being maintained. So from the point of view of exercises, expansion exercises, a lot of talking is also good because you need breaths, holding of the breaths, and shouting is a good exercise, and singing. These three promotes good respiratory health of the patient. Next. Postural education is also important because continuous sitting, the patient has got a protruded chin, kyphosis, lordosis. So postural exercises is important. Next. Patient education is also important, and the patient should know whenever he is doing exercises on his own, awareness of warning signs. If the patient has dizziness, chest pain, excessive fatigue, please stop the exercise immediately. Next. So what you need to do as a physio, most important, avoid exercise on the dialysis exercise. Monitor blood pressure closely. Avoid exercise immediately after dialysis if the patient is fatigued. Adjust intensity based on hemoglobin levels. Maintain proper hydration as advised by the physician. Next. And in peritoneal dialysis patients, core strengthening with very, very caution, and again avoid excessive intra-abdominal pressure to this patient. Next. So again after physiotherapy after renal transplantation, early mobilization, breathing, gradual strengthening, posture correction, and long-term fitness training is an important aspect for the CKD patient. Next. So this we have already spoken benefits of physiotherapy. Next. So what is the takeaway message about physiotherapy rehabilitation? It is safe, it is effective, and essential component and integral part of comprehensive care in rehabilitation. Next. So a structured and individualized exercise program. Individualized exercise program is very, very important. So a structured and individualized exercise program significantly improves physical function, reduces complications, improves functional capacity and quality of life in patients. Thank you. I'm sorry for the extra time.
Something I want to do. जैसे हमने जेफार कहा है, जेफार के हमारे इसमें जो है हम स्टेजेस हाउ मच कितनी डन तो पहला स्टेज सेकंड स्टेज थर्ड स्टेज where we do clinical. So in first and second stage, we can manage exercise program that it can जैसे कि उसको एक तरीके का प्रोग्राम हम बिल्कुल स्टेज में उसे मैनेज कर सकते हैं क्योंकि उसकी जो लाइफ है वो सोफिस्टिकेटली और अच्छी तरीके से चलते हैं साथ में जैसे जैसे उसका प्रोग्रेस जैसा होता है उस हिसाब से हमें उसका जो एक्सरसाइज प्रोग्राम जो फिजियोथेरेपी प्रोग्राम उस तरीके से हमें मैनेज करना पड़ेगा जैसे लास्ट पेज में अभी हम सारे जो भी मैम ने हमें काफी अच्छी तरीके से एक्सप्लेन किया है, लेकिन हम इस पेज को पहले से जैसे ये पार्ट जैसे डिटेक्ट होता है और हमारे नेफ्रोलॉजिस्ट हमें इस हिसाब से गाइड करते हैं कि डाउन पेज और इसके साथ में जो उसके लाइफ स्टाइल जो है हम उसकी अगर चेंज ला सकते हैं, उससे हम उस डिजीज को हम काफी हद तक रोक सकते हैं। तो हमें नेफ्रोलॉजिस्ट एंड फिजियोथेरेपिस्ट हमें इस तरीके से मैनेज करना पड़ेगा, इस तरीके से हमें कोऑर्डिनेट करना पड़ेगा ताकि हम उस पेशेंट्स को उस लेवल से उसे प्रिवेंट कर सकें। नाउ वी विल मोर फोकस ऑन प्रिवेंशन। तो एंड देन जब पेशेंट की कंडीशन है तो उस कंडीशन में फिर हमें जिस तरीके से मैम ने सजेस्ट किया है उस तरीके से हम पेशेंट को हेल्प कर सकते हैं। उसकी लाइफ उसकी जो दिक्कत है उसमें हम लाइफ ऐड करने की कोशिश करते हैं। दैट वी कैन। थैंक यू।
It was a very nice, thoughtful, and an insightful session. We also could learn a lot from the role of physiotherapy, how it will help in our rehabilitation. Thank you.
Dr. Mandir. For our next session, we invite Dr. Ashwini and Dr. Tukadoji, kindly offer their Dr. Suresh Pandya is very cultural and educated nephrologist. She is expert in kidney transplantation. Dr. Subodh Katlecher is an orthopedic physiotherapist, director at Pro-Clinical Physiotherapy Clinic, Advanced Achievement in Spine Care. Dr. Krishna Tete is requested to welcome Dr. Suresh Ma'am and Dr. Subodh Katlecher. Chairperson, please take over the proceedings. Please introduce our speaker, Dr. Tukadoji.
Now the stage is set, momentum is built, and we have now understood that individualized, gradually progressive kind of physiotherapy is important for the patient to maintain strength. And now the apex body, that is kidney disease, improving global outcomes, has again re-emphasized the fact that maintaining the physical strength in a CKD patient is the core goal of CKD care. Now it is not an additional goal, it is the core goal that we should see that from beginning, the physical strength of the patient is maintained. So how do we do that? For knowing that, how do we put this knowledge into practice? We have Madam Dr. Shilpa Chaurasia. She is a professor and head of musculoskeletal physiotherapy
SPM College, Nagpur, and Madam is specialized in complex musculoskeletal dysfunctions and oculomotor rehabilitation. She has a huge experience of 23 years in teaching, and she has many international and national publication and awards to her credit. Over to you, Madam, to guide us on how to take the assessment and to provide individualized care to the patient.
Very good morning, Professor, my teachers, my everyone, you have taught me in final year. My friends and my students, today I am here to discuss physical assessment protocol in CKD patients. So in CKD patients, there are certain physical body functions and structural impairments. These are broadly categorized as primary impairments and secondary impairments. So the primary impairments, the most common impairments are sarcopenia, pain, reduced mobility, reduced strength, endurance, quality posture, postural instability, and balance issues. Some of the secondary impairments are reduced aerobic capacity, obesity, cardiovascular issues, and depression. Now, it is important to consider these impairments because through assessment, it is to get the idea about these impairments from patient's perspective as well as clinician's perspective, and to understand the basic physiological base of these impairments. Next. Okay. So this is the protocol which is relatively more concise and it is more objective and it follows the principle of SOAP, that is subjective assessment, objective assessment, assessment and plan. So the first component and important component in CKD patient assessment is myotome assessment or the muscle testing. So for muscle testing, all of us are aware about the MRC scale. MRC scale is a very commonly used clinical method to assess the strength of muscle or the muscle force. Now, according to this scale, which is relatively commonly used, it has a good reliability also, and according to this, it doesn't require any specific instrument. So that's the best thing about the scale. So according to the scale, there are 5 grades, and the movement performed by the patient, whether the patient is able to perform the movement against the gravity, in a gravity-limited plane, submaximal resistance or maximal resistance, the muscle is graded as 0, 1, 2, 3, 4, and 5. So from these grades, we understand the basic integrity of a particular nerve supplying that muscle. So using this method of assessment, we can grade a single muscle or the group of muscles. So if we want to assess the integrity of L3 nerve root, we can do the extensive and using the resistance or using the quality of movement, we can grade the myotome. So this is called as myotome testing or muscle testing. Next, please. But this is relatively, MRC grading is relatively subjective. So to get the more objectivity in this, we can use dynamometer. So dynamometer is relatively, it is available, but relatively expensive component in the assessment. So it gives you the more precise reading of the muscle force. So it adds objectivity to the finding. So that's reducing the subjectivity and it gives the findings which we can use for the longitudinal assessment. So it is relatively more reliable. So hand grip dynamometry is commonly used in CKD patients. The average of 3 consecutive measures obtained at an interval of 30 seconds, 30 seconds can be used for the analysis of the strength. So this is the important component in CKD patients, that is sarcopenia. So why evaluation of sarcopenia is important in CKD patients? It is one of the main complications verified in CKD patients. And CKD patients, this is because it is the premature aging is generally associated with the CKD patients. Now, according to the literature, approximately 26% of patients on hemodialysis are prone to sarcopenia compared to normal population, that is only 3%. Also, this prevalence increases in hemodialysis, which approximately goes up to 63%. Now, half of the sarcopenic patients are talented, that means they have reduced strength. Apart from reduced muscle mass, they have reduced strength, which is actually important in rehabilitation. So dynappenia is the important component in sarcopenia, and it is of great prognostic value in the rehabilitation. So the prevalence of sarcopenia increases in line with the progression of stages of CKD. Sarcopenia and physical inactivity synergistically progress, so has a negative impact over the quality of life. So these findings suggest that sarcopenia should be evaluated and carefully, and that the prevention and mitigation of the progression of sarcopenia and physical inactivity are important to improve the prognosis in CKD patients. Now, there are multiple methods to assess sarcopenia, quantitative methods as well as qualitative methods. So the quantitative methods, there are 3 quantitative methods which are commonly used. These are muscle quality index. Now, the muscle quality index can be assessed with the help of handle strength and BMI. So if the muscle quality index is less than 1 in males and 0.56 in females, that suggests the sarcopenia is present. Second component is hand grip strength. 27 kg, less than 27 kg in males and less than 16 kg in females suggests that the sarcopenia is established. There is one more component, that is gait speed. That is called as also cadence. If the gait speed is less than 0.8 meter per second in 4 meter per minute, that suggests that the patient has established sarcopenia. Next, please. So, considering the sarcopenia, the various body composition methods are also used, but the equipments are very costly. So, the physical measures can be used to assess the sarcopenia. The SARC curve is one such physical measure which gives the presence or the grading of the sarcopenia. So, according to this scale, which analyzes strength, assistance in walking, rise from a chair, climbing stairs, falls, and calf circumference. So, as such, it is functional because it is using multiple components which are used in activities of daily living. So, according to the scale, if the score is between 0 to 10, it suggests low risk of sarcopenia. If the score is more than 11, that suggests established sarcopenia. Next, please. Coming to functional performances, these performances are important because these are the tests which uses functional activities. So, assessment of functional activities using this test is highly effective or applicable in CKD patients. The first is time up and go test. It's a very simple, quick, reliable, and widely used assessment for mobility, balance, fall risk, especially for the older adults. After a trial of familiarization, patients are timed while rising from the seating chair or the seated chair, walking 3 meters. So the time taken to complete this test is actually decides the level of functional capacity. If it is between less than 12 seconds, the patient has good mobility, good balance, and low risk of fall. If it is between 12 to 15 seconds, then definitely there is increased risk of fall. Next, please. Now coming to postural control. Postural control is basically maintaining, achieving, or restoring the balanced state in various physical activities which are required in day-to-day activities. This is the scale which analyzes the postural control and balance. So in this test, whether the patient is able to hold the position, maintain the balance with or without support, and that means with or without extra swing. All these factors are analyzed and accordingly the grading is done as 0, 1, 2, 3, and 4. 0 suggests that the patient needs active intervention, specifically the physiotherapy intervention, and the 4 is normal where patient is able to hold the position against the resistance with a minimal postural swing. Next, please. This is rhombus test for the static balance. If the rhombus is done in a closed standing position, then that is rhombus test. If it is in a walk standing position, that is shuffle rhombus test. This test is mainly done with the eyes open and eyes closed. So if the patient is able to hold this position without sway, without taking any implementing any strategy, that is hip strategy or ankle strategy, in that situation, the patient is supposed to have a good balance. Next, please. Functional reach test. The test provides a quick screen of balance problems in older adults. It is the maximum distance one can reach forward beyond arm's length while maintaining a fixed base of support in standing position. The test uses a level of yardstick mounted on the wall. So basically, it is for the static balance. Next. This is important. This is functional independence measure. This is the scale which can be used to assess the fatigue also. This is the scale which analyzes self-care, sphincter control, transfer, locomotion, and social cognition. So in this, according to the different levels, the functional state of the patient is decided. Next, please. So during performance tests, perceived level of fatigue can be documented using the Vogue scale for rating of perceived exertion. That means exertion can be graded according to the scale also. Next, please. Yes, the obesity is the major concern in these patients because obesity is negatively associated, correlated with the muscle quality index variables and hand grip strength. So, higher obesity indexes will negatively impact muscle strength and mass in CKD patients. Obesity should, so that is why obesity should be considered as a preventable measure in the management or rehabilitation of CKD patients. BMI is commonly used. There are multiple methods by which we can assess obesity. The most commonly used method is BMI, which is easy, applicable, and does not require specific instruments. But BMI cannot differentiate or distinguish between fat mass and the lean body mass. So there are two other components which can give you these components. These are waist circumference and waist hip ratio. Next, please. So the waist circumference, if it is definitely more than 102 centimeters in males and 88 centimeters in females, that suggests a major concern, central obesity is present. Waist circumference is strongly associated with the all-cause and cardiovascular mortality in CKD patients. Next, please. So this is the way waist hip ratio is calculated. If it is more than 0.85 in females, and more than 1 in males, that suggests the high risk, and active intervention is required, rehabilitation is required. Coming to musculoskeletal disorders in CKD patients, it is very much common in CKD patients. The most common feature present in CKD patients is pain. So the pain, fatigue, cramp, muscle atrophy, sedentary behavior, and disability, all these together facilitate negative effect and establishes the inactivity. So through the inactivity, muscle deconditioning, there is obviously compromised quality of life. So considering these aspects in CKD patients, certain questions can be asked regarding the onset of symptoms, location of symptoms, quality of symptoms, pain assessment. Now the pain assessment can be done with either from a visual analog scale or numerical pain rating scale, or there are multiple other objective methods also by which you can quantify the pain. Now the pain, we have to differentiate whether it is a neurogenic pain or muscular pain. If at all it is because of muscular pain, is it because of muscle spasm, muscle inhibition, or trigger point formation, or it is kind of radiating pain or a referred pain? Because in all these types of pain, the management will be different. Okay, so then the general medical history, specific history, occupational recreational activity assessment is also important, and anthropometric characteristics. The assessment of all these components is important. Now, the crystal-induced arthropathy is very common in CKD patients. Also, involvement of certain joints is also very common in CKD patients, mainly the shoulder joint and the knee joint. So accordingly, we can assess these joints, affected joints, according to the special test. There are multiple special tests. We can use those tests and decide the management according to the positive findings. Coming to the quality of life, the kidney disease and quality of life 36 is used to assess the health-related quality of life in dialysis patients. It is a self-administered questionnaire. There are 80 items. Out of these 80 items, the majority are related to the, so that means these are related to the various components of a person. So these 11 domains are there. The score is the maximum score is 100. Higher the score, better is the quality of life. Next, please. Thank you.
Thank you, ma'am, for this. My one question is, while taking assessment, can we take in consideration about GFR?
Yes, definitely. GFR has a direct relationship with the present status of the patient. So that we have to consider. That's why I have mentioned the medical history.
And also, can we plan the exercise protocol according to GFR?
Yes. Yeah.
Thank you, ma'am.
Yes, pain is multidimensional component. So if obviously retention is there, the muscles are affected, bones are affected, tissues are affected. Each and every component related to the joint, around the joint is affected. So that is obviously one of the reasons for pain. And can we use pneumatic compression or pneumatic compression we can use, but it has certain limitations in security.
Just as the nurses they realize that the nursing diagnosis is different from medical diagnosis, and they have created a long list of 101 diagnoses by an American association. The dietitians also realize that the nutritional diagnosis is necessarily different from the medical diagnosis. So in the nutrition care process, we have devised their own diagnosis. And the physiotherapist taking any such step.
Till now, it is not so, but definitely with this symposium we can.
So basically, it is more of we rely more on functional assessment.
Functional assessment.
So as we said, each and every part which we are assessing, because we treat the person as a whole when we are treating the joint or when we are treating a particular body part. So assessment goes along with the patient. So that is why I said individualized assessment and individualized programs are the key. I do not believe in generalized basically, because like even if a patient can have a greater GFR but if he is active, like simple example, Sanjay is a marathon runner, right? As compared to I think so is a non-athlete. So if we look at both of their activity level, it is going to be different, isn't it? So it is more of individualized assessments and management protocols, which I personally believe are more important than the generalized protocol.
Individualized assessment and risk stratification of that individual, whether he is a low risk, moderate risk, or high risk, and accordingly to plan individualized kind of strengthening therapy for him. I think, and reassessment at regular intervals, setting goals, they will go actually a long way in finding care for a particular.
You can definitely have a, for example, if a 35 years male is having knee pain at a CKD patient and a 65 years male, we cannot compare. So the demands in 35 years male will be different compared to 65 years. So accordingly, we can plan the individualized program and requirement.
That is why I think the GFR we cannot consider so much. My personal opinion for what patients I have seen as a generalized case for physiotherapy management. Because physiotherapy assessments are going to be more on physical basis of the patient. GFR definitely will have levels. The levels of GFR will definitely have different levels of activities of the patient. That's what the GFR
and to actually gauge how the patient is. What can be
actually GFR is not the only factor.
It is one of the factors to understand the patient better. And depending upon quality and all other things, that actually risk that we should categorize that patient into risk category and accordingly devise certain kind of a specialized, individualized
risk category. Basically, risk category. So we can categorize him into the risk, like what can be given, but what cannot be given.
Yeah, as
so
you
risk
mentioned,
stratification is very important.
So GFR should be taken into consideration with respect to the risk stratification that we are taking for Tukadoji.
Yes, exercise tolerance, degree of surgery, all these can help to stratify a patient and to define a specific protocol for patients.
So there will be a you give a score for each risk factor, then sum it up, and maybe you have a single score, and then divide the population of patients into different classes. The score of 25.
This is the ideal way to do, but in our conditions like in India, where we are basically very low on integrated kind of care for CKD patients, at least considering what the madam has said, like functional testing, exercise tolerance, RB, this can be helped as good methods to categorize the patient, at least to begin with. And once the program picks up, then probably with our more experience and learning, we can have some scores and we can define our own risk criteria for the patient in a more objective way.
That's what is the topic.
So SOP can be developed for that purpose, so that there are some guidelines how should we proceed. Right from the beginning, when the patient has been diagnosed with CTD or diagnosed with a kidney injury, and then the guidelines will guide you to how at each step who is going to be fasting or who is going to be intervening. So that will be a good idea to develop the guidelines.
Thank you, madam. The basics remains the same. We have to assess the patient with RP, muscle strength, adequate functional tolerance, and all of it. Thank you for the insightful talk. We have learned a lot.
I should be chairperson to kindly present the subject to our speaker, Dr. Teresa.
For our next session, I will Dr. Piyush sir and Dr. Ashwini ma'am to kindly offer their
आप चेयर पर्सन है मैडम यू
Dr. Piyush sir is a consultant nephrologist and current president of Nephrology Society. Dr. Ashwini ma'am is a retired senior occupational therapist. She continues to inspire generations of therapists and healthcare professionals with her dedication and compassion. I request Vaishali Katole ma'am to welcome our chairpersons with samples. I request chairperson to take over and introduce our next speaker.
Good morning, everyone. Sophia Azhar, madam has been a Bachelor of Science in Occupational Therapy from Nagpur University. Post-graduation in specialization in orthopedics from University of Nagpur. She has been a clinical supervisor and head at the Occupational Therapy School, Government Medical College and Hospital in Nagpur, India. She has various publications up to the present. She she has been appointed as a PG supervisor by Nagpur University and PG Graduate associate editor of IGOT from 2010 to 12. Also has been awarded the fellowship of ergomedicine and honor of ergomedicine research academy for research of recognition of research work in the field of ergomedicine. And she has also bagged the late Renal Award for Excellence in Vocational Service 2013, presented by Rotary Club of Nagpur.
As I said, I would like to thank Dr. Kalkar for giving me this opportunity. I am a member of society, Dr. Maharaj, and we really overwhelmed by the presence of overwhelming and professors who are teachers, we have mentored all the time and guided me on this stage. Thank you, Rajeshri ma'am, for giving me this opportunity. My dear colleagues and my dear students and friends. So today my topic of presentation is all about role of occupational therapy in renal rehabilitation. We will walk through the areas where occupational therapists are dealing with these patients and really thank Dr. Umanjali ma'am and Dr. Shilpa ma'am for giving us so much insight into the condition and also the way the therapy or the rehabilitation should progress. So here is my you can say opinion about occupational therapy. Next slide, please. So chronic kidney disease is defined as a progressive, irreversible disorder of kidney function that leads to a series of biochemical, clinical, and metabolic changes directly related to increased morbidity and mortality, as said by WHO. CKD or chronic renal insufficiency represents a significant and escalating public health problem, and it has creates a substantial burden on patients, their families, and their healthcare system. Next slide. While sustaining medical treatment such as dialysis are critical in managing, they often coincide with a profound decline in the quality of life, the patient function, and well-being. This deterioration creates critical gaps in care and a compelling need for comprehensive rehabilitation services for patients during rehabilitation. So comprehensive rehabilitation services, we are all talking about just now. So here, what will we do next? So what are the areas because of chronic kidney disease? What areas will be affected? So physical and functional decline. In this, it has been said that the patients with CKD will have decline in their aerial activities up to 20% in their areas like eating or grooming or those things. And that is the BAD, the basic activities of daily living. Whereas in eye area, there is staggering 80% decline. Means they will not be able to do cooking or medical management like medicine management and all. So you can see the burden. Then the psychosocial and emotional burden. They will undergo a lot of anxiety, depression, also sort of also spoken about it and other people. So the amount of psychosocial and emotional burden will be, I mean, it may not be seen earlier, but it will be there in the patient, which will he will not be able to verbalize it. Cognitive impairment. This is very important. Mild cognitive impairment starts occurring because of the uric acid which is there present in the blood, and because of that the white matter is damaged, and because of that the patient will have problems with memory, attention, and executive functions. Then occupational and social role disruption. Obviously, if the patient is having to go for the kidney disease, that I mean for the treatment of the kidney disease regularly, so he may not be able to socialize his work will be affected, and it has been seen that only 21.7% of people are in the job roles or they are doing their work. Otherwise, they may have to leave their jobs because of their impending situation. Next slide, please. So, what is renal rehabilitation? Next slide. Renal rehabilitation is a coordinated, multifaceted type of program which optimizes the physical, psychological, social functioning, stabilizing, slowing, and also maybe reversing the condition. Not reversing exactly the condition, but the cognitive impairment or the, like Madam said about talked about the muscle wasting that can be reversed. Next, please. So these are the 5 major components of renal rehabilitation: exercise training, medication and medical surveillance, education, psychological and vocational counseling, diet and fluid management. Now, in this, there are 5 E's which they have said about how you should be managing about the patient. So, encouragement to the patient, then employment, education, and evaluation. All these factors also go a long way in renal rehabilitation. Next slide. So, what is occupational therapy? Occupational therapy is a health profession that utilizes daily activities, that is occupation, therapeutically to assist individuals in achieving their desired and necessary tasks with a focus on enhancing occupational performance. What is occupational performance? Anybody from my students or my colleagues? Occupational performance is basically about how one is doing their daily routines and in what manner, how they are patterned and how they are progressing with it. Occupational performance refers to ability to perform tasks that facilitate the fulfillment of occupational and social roles satisfactorily for the individual stage of development, the culture and environment. So we don't look only into the person individually, we also look at the other areas, that's the cultural background. That is very important for inclusivity. Or for actually, because see, there are so many different cultures we need to imbibe, or we need to be sensitive towards. So we cannot say कि नहीं आप ये culture से आ रहे हो तो हम आपको नहीं treat करेंगे. So that cannot be. In India we are very well placed because we have a different culture in our society and we relate to it very well. But in other countries maybe it will be so difficult. Next slide, please. So it is the background for evaluation. So for in occupational therapy, we highly rely on these factors. That is the model of human occupation. Is a body of theory that seeks to explain how occupation is motivated, patterned, and performed, and how illness and disability related problems arise. So how a particular you can say area activity, or if I see the cultural differences. So I may be treating a Muslim patient, I may be treating a Hindu patient, whatever. So I have to be sensitive that the Muslim patient will need to do namaz, practice namaz. The Hindu patient will have to go to the temple. So these cultural sensitivity is important for us. And how they are patterned. Pattern means how the person performs that activity of daily living or behavioral or IADL, and perform and how illness and disability related problems arise. So we use highly recommend the Canadian Occupational Performance Measure. Is an evidence-based assessment measure designed to detect changes in the individual's perception of their occupational performance over time. So when we start with the rehab process, first we ask the patient to define at least 5 roles which he would like to do in his daily in his life, like daily routine. And then after rehabilitation, we assess the satisfactory level of the patient. So this is how we go about framing the goals of treatment and then implementing the treatment protocol and then finding whether the patient is found satisfactory or not. Next, please. So what does an occupational therapist do? An occupational therapist can identify problem areas that a person may have in their everyday life and will help them to work out practical solutions. So that we will know what they need to do. Okay, what the person needs to do on a day-to-day basis. That is very important to us. We do not ask him like what you want to do and what you need to do. We ask those questions. Next, please. So daily tasks can include getting on and off the bed, chair or toilet, walking indoors and outdoors, managing steps and stairs, getting in and out of the home, washing, dressing, bathing, domestic tasks, leisure and work activities. So these are the daily routines that the person makes, and we do an activity analysis. Activity analysis means we break down the activity in small steps and we find out which part of the activity the patient is unable to perform so that we can give them a different strategy. Next, please. So how can occupational therapists help? To see if there is any other way. Is there any other way to do a particular activity? So we will question ourselves कि हाँ ये रिसर्च में कर रहे हैं तो ये इसको यहाँ पर बहुत एनर्जी कंजर्व हो रहा है. So what can we how can we help them to do it in another way so that it will be more easier for them and we will be more independent. Altering an environment. So we may ask the caregivers maybe to install grab bars or high toilet seats, or we can give them walking aids to the patient. So we can alter the environment. Special tools or pieces of equipment. Again, some kind of assistive devices can be given, which will it will be easier for the individual to do the particular activity. Like the ma'am said, there can be joint stiffness, there can be poor grasp because of muscle wasting is there. So we can help with better handled tools with some very low cost aid which can help the individual to be independent. Basically, our goal is that the patient should be as independent as possible and so as to reduce the caregiver burden. Advice regarding reference among other services. Very important that you, as an occupational therapist, you are sensitive for the individual's performance and our occupational performance, and you find something is not something which you cannot be able to achieve, or which you should be referring to other services, you should immediately do that. Next slide. So activities that can be encouraged for the individual. And how he should be involved in the treatment process. It should not be very mechanical for the patient. So next thing. So recognizing your strengths and weaknesses. So we should have a counseling session or maybe a talk with the patient. What are his strengths and weaknesses? To know about each other and practice collaboration skills. So what collaboration, like as a therapist, what I will be giving to you and what you will be giving to me. Like, if you have a clear conversation, a collaboration, then it will go a long way in helping the individual. Application of knowledge on diet control, so that can be also with the nutrition the patient can talk with. Organize own schedule and plan for the future. Very important because the person will be in anxiety. कि मेरा आगे क्या होगा, मेरा फ्यूचर कैसे होगा, what will happen, whether I'll be still employed or not, how will I, the financial part is very, very important. So how will I organize that? Then reinforce self-management of the disease and problem-solving skills. So how we can strategize or how we can explain the patient in self-management क्या होता है, क्या आप किस तरह से आपकी जो condition है उसको कैसे recognize करोगे, some small symptoms or signs which you see, how will you recognize, and then you can do self-management. So problem-solving skills also can be taught to the patient. Next, please. Enrich leisure and social life. It is very important because of the condition, the patient is continuously going for dialysis at least 3 times in a week, and because of that, he is losing time on his leisure activity and social life. So that enriching leisure and social life is also an important aspect of keeping the person from depression and anxiety. Learn and practice ways to appreciate self and others. So obviously these are, you can say in community living it is very, very important. Tracing previous work, what previous work was and how he did it, and now how it can be changed or or simulated kind of other work can be implemented. Then cooking sessions to facilitate communication and collaboration. So, everybody enjoys that, so that can be one of the areas where you can intervene. Next slide. So therapeutic process in occupational therapy deriving the following themes. So what are the themes as an occupational therapist we should be looking into while we are treating patients with CKD? So actions of occupational therapists with the user, that is the patient, or the client as we call them, the caregivers, family members, and team participation. So team participation is the multi-disciplinary team which we have. Next slide, please. So the first theme is initial contact and reception of needs. So establishment of therapeutic bond. So the American Occupational Therapy Association has a very good program on how we should be bonding therapeutically, because that the first what we say rapport building. Okay, so rapport building with the patient and the needs survey. Okay, what he needs to do, what he wants to do, and then once the therapeutic bond is established, then the person, the patient or the client will be, calm and will be able to tell you more about his lifestyle and all. So we can be more enthusiastic about how the goals will be set and other things. Identification of the social support network, that is the social support network is the immediate caregivers, the family members, the extended family members, the friends who would be able to help the person in taking care at the hospital also, or other financial aspects also. Next please. The second thing is about support for resignification of the health disease process. So resignification, that the person should not feel कि मेरे emotions pattern नहीं करते. Okay, he should be having that say in his condition and should be heard by the therapist, by the physician, and other team members. So valuing psycho-emotional aspects, okay? Interaction with the family members and caregivers, very important to educate them why, how, when, where, what is needed for the individual, and how much amount like maximum we should not बहुत उनको प्यार से है मतलब और उनके साथ उनका सब काम नहीं करके देना. That's very true, because otherwise we will lose so many things like the mental wasting will start or the cognitive ability will be declining one. Rescue and discovery of new interests. So now the person has stopped going to his work. He may lose his job. So now what new interests can be developed in the individual, or depending upon the education level. Nowadays we have a lot of social media and online jobs are there. So person can be diverted towards that, so that his financial condition also does not go for a toss. Next please. Third theme is about assistance to adapt to the new health conditions. Okay. So need for health management and maintenance. What management and maintenance of the individual will be like about the physical aspects can be about exercising, about doing meditation or yoga or breathing exercises, facilitate self-care performance. So person should still be involved in his self-care, and the caregivers should not be very enthusiastic about doing all the activities. So self-care management will also help the patient to maintain his self-esteem. Next please. Fourth theme is about preparation for discharge and a new routine of care. So once the patient, suppose he was hospitalized and now the discharge is there. So discharge planning actually starts very early. And discharge planning should be done by, because we have to, as an occupational therapist, you will need to go to the home of the patient, find out what kind of home he lives in, what kind of assistance devices or what kind of modifications are needed, and accordingly, when they are at home, all the things are in place before the discharge. Reinforcing the community of care in the health network. Next please. So I've just taken a case study of a person
who is a 38-year-old right-handed male patient from Nagpur, farmer by occupation. He was diagnosed with CKD and on hemodialysis in 2023 with complaints of generalized weakness, fatigability, nausea, pain at time of dialysis, low mood. Also in 2024, patient complained of sudden weakness in right upper limb and lower limb with clear speech, which improved in 4 to 5 days and recovered completely after 1 month. Patient had one episode of seizure in 2024, and after 6 months, after this, patient is kept on dialysis for 3 times per week. So since 2024, he is on dialysis. Family history: patient lives with a 75-year-old father and mother, 65-year-old. Father is also a farmer, and brother, 27-year-old, is also a farmer by occupation. Surgical history of fistuloplasty done at proximal AB 2 times and right distal AB fistuloplasty done in June 2025. So reason for the client is seeking services and concerns related to engagement and occupation. So why is the client seeking services? So first is difficulty performing heavy work because he is a farmer. He needs to lift heavy loads of things. Patient feels fatigue after farming, and particularly on days of dialysis. Muscle cramps and calf muscles after dialysis. So these are the basic answers about the patient, what he is seeking services for. Next, please. So these are occupations in which client is successful and barriers affecting the success. So what are successful? All is ADL, like eating, dressing, rest and sleep on other days than dialysis. Okay, so on dialysis days we still have problems with sleep, which is a very important aspect of health. Willingness to do work and help family members, grooming and personal hygiene. So all this he is successful in, whereas barriers are painful dialysis, economic conditions and fatigability. Next please. So occupation history: he received formal education up to 9th grade, went to Aurangabad for working in a private company and returned to village and started farming along with his father and brother, and he goes to the farm by his own wife and supervises his workers. Personal values and interests was very important aspect of the whole development of occupation therapy. So he's interested in playing cricket and values being independent in all his areas and hospital expenses. So he values it. I mean, मुझे अपना independent काम करना है all my areas, and he also manages to his hospital expenses also. Next please. So personal factors: he is independent in all his areas. Supporting engagement and inhibiting engagement is stress, overthinking about the disease condition, and being unmarried. So you can see how at every aspect of the life we have to look into, and we have to maybe we have to intervene or give some counseling to them. Next please. Environmental factors: supporting engagement is with supportive family. Family is good. Inhibiting engagement, access to the dialysis center. Now, because the person is from the rural area, he has to travel a lot to come to the dialysis center, and there is less job opportunities in the rural area where he can perform night job. So performance patterns, that is routine, habits, hobbies, roles and rituals. On dialysis days, he wakes up at 6 a.m. and performs BADL, that is taking bath, and his breakfast around 8 a.m. Reaches for dialysis at 10 a.m. and returns back home after 4 to 5 hours. On normal days, after performing breakfast, goes to the farm. Habits: there are no specific habits. Hobbies: he likes to play cricket. Roles of son and brother. Very important role. What is your role as you are a person, human being, or you are someone's brother, you are someone's son, you are someone's husband, or whatever. So those are the roles and rituals, that is goes for walk every day. Next please. So these are the body functions. These are supporting engagements are that he has got intact. All the other functions, that is mental function, there is no cognitive deficit which has been evaluated by MOCA.
intact sensory functions, visual system, respiratory, neurovascular skeleton, hematological, and immune system, digestive, metabolic, and endocrine system. So you will say that why you are doing evaluation and what is your part in intervention. So we will talk about that. Activity intolerance is there. He cannot sustain for longer periods of time. Post-dialysis fatigue. So after 4 to 5 hours, naturally, because of the compromised kidney functions and all, there will be fatigue. Weakness for 1 to 2 hours after dialysis. Pain at time of dialysis at the granular site. Moderately decreased endurance. Hypertension since 2023 and oligonuria. So these will be the inhibiting engagement that the patient is having. That means these are the problem areas where we will be looking into and how we are going to intervene. So next please. Body structure. Structures of all systems are intact, as we said earlier. Standardized scales that we used was modified Watson index, fatigue severity scale, and kidney disease quality of life. Next please. So the performance skills. So motor skills supporting the engagement and farming are adequate. He has good body alignment and posture, good grip and coordination, adequate reaching and bending. Supporting process skills are focused on routines, follow sequence of farm activities, aware of safety rules, and social interaction performance skills, initiates communication, expresses concerns, relates to other people. These also how the mental processes are going on in the individual. So that also needs to be assessed. Inhibiting motor skills will be like fatigue, unable to regulate or pacing the activity. We always tell energy conservation technique. You have to pace the activity. You have to do some part and then rest, and what Madam also emphasized upon. Lifting heavy loads, slowness and cramps. Then inhibiting process skills are difficulty managing workload. Fatigue causes errors. So when like at the end of the day, when we are really mentally fatigued, we all create errors in our work. Okay? So that may be earlier for these people. So fatigue will cause errors. And inhibiting social skills, that is hesitant to ask for help. He is in a state like he's a 38-year-old. So he is like an adult. Was young adult you can say, and he may have that how should I ask you which चार दिन बोलते हैं कि वो उपयोग उसको कि मैं कैसे पूछूं तुम तो अच्छे खास हो and why you are asking for help. So that is hesitant to ask for help. Social withdrawal may be there because he needs to go thrice in a week to the hospital for a year, and that's why he has lost his strength of the other social engagement. Next, please. So, function independence measure, when we get a total of 126 out of 126 we got, is obtained with studies that patient is independent in activities of daily living. 13 severity scale, we got a total score of 40 out of 63, and the score independent patient has moderate fatigue. So, 36, I think, out of 63 is 54, it is moderate, and it is severe fatigue. Next, please. Kidney disease quality of life scale, we got a score of 54, and your components such as your health, your kidney disease, effect of kidney disease on your life, these scores were 68, 20, 28 and 66 respectively. So the effect of kidney disease on your kidney disease, so that has components like how, what do you know about it and all that. So it has got a very low score. That means the person is not much aware of this kidney disease and how it is progressing or what is the end result of it. It is a great high. Yeah. This one. Problem is identify the post-dialysis fatigue, decreased strength, weakness for 1 or 2 hours after dialysis, pain and time of dialysis at the cancer site, and moderately decreased endurance. So these are the OT intervention program, work on energy conservation and work simplification, self-identification of fatigue level and pacing activities using 4 P's, that is prioritize, plan, pace, and position, breathing exercises, meditation, engage in leisure activities, improve cognitive function, and CBT for lifestyle changes and management. These are the of mainstream. So end result of the OT process, what the OTs will achieve, what client can achieve through OT intervention. Outcome categories are occupational performance, that is daily work leisure, improvement in endurance, enhancement of independence, prevention of muscle wasting and cognitive decline, health and wellness, reduce anxiety, well-being, that is loved and cared for, well competence, fulfill life goals, and quality of life, participation in occupational justice. Occupational justice is about employment, interest, and pursuits that a person will able to go for. Thank you so much for patiently listening.
Thank you, madam. You have presented us with a spectrum of possibilities under occupational therapy, which patient can be managed. I just wanted to, can you just sum up for simplification? When can a patient be referred to occupational therapist? At what level, at what stage, or at what
Rehabilitation also. When the condition is diagnosed, but I think about the three different. So first thing is about the diabetes. So since the time of also because you are since then on the therapy start. So that is very finding out all the related option focus can include that will be the first and talking about caregivers, employment, everything like it will start right from the beginning. And that will, gradually, that will also help the person to reduce the length of stay in the hospital and repeated hospitalization. So, the pre-rehabilitation is another concept.
For OPD patient.
In this hall, we have nephrologists, physiotherapists, and occupational therapists, basically avengers of the kidney care. Thank you so much, ma'am. To bring this session to graceful close, we request chairpersons to present chaplain to Dr. Sophia Azarna.
Okay. In 5 minutes, I will be trying to explain what is occupational therapy. First of all, I would like to introduce myself. I'm a super senior retired in since 30 years from occupational therapy. I was attached to orthopedic center and all orthopedic conditions and all physical conditions. Now I will start 5 minutes, please. A very promising knowledge has been given by all professionals, Dr. Rupaja, Dr. Timaskar, all professionals like physiologists, Dr. Duncan, Dr. Pasha, Dr. Azad. They have given me complete knowledge of nephrology. Respected Dr. Dhananjay Upalkar, yes, renal rehabilitation by both physio and occupational therapy is the need of the hour because chronic kidney disease is a worldwide rising rapidly and is becoming a priority of health problem, causing number one, function limitation in the patient, leading to impaired severe structural disability
and this gives a poor quality of life. Now, what are the functional limitation which includes muscle weakness, which you have already told me, leading to reduced capacity in mobility, which becomes a very challenging problem for with fluid retention, muscle dysfunction, anemia, leading to organ damage and structural abnormality, it results in a very poor quality of life. So importantly, I request Dr. Tukadoji, early referral for occupational therapy is a necessity to prevent functional decline, to present issues leading to cognitive and emotional limitations, which develop due to limited fluid, eating low protein diet, developing mobility and structural weakness. So early second important factor is the therapist is given occupational therapy. All should remember, along with all the evaluations which you have given in detail about this patient. Patient's self-reported limitation has been said. What he is reporting his limitation, here that was. You do not keep on doing your treatment immediately. Ask the patient, what are your limitations? That is very important. It will reduce. What is reducing his endurance? What does he want? What type of a help he wants? And area task for physician occupational therapy. All this has to be asked by the patient. His limitations has to be understood first. Your analysis continues. In occupational therapy, rehabilitation consists of patient-centered approach. Everything has to be patient-centered. Approach in daily tasks. We give assistive devices. I can explain that dressing sticks are made to pick up and pull the clothes, to put on the button. Such sticks are made. Then long handles for shoe wearing if they cannot bend. Such assistive devices are needed by the patient. Splinting are given if the patient is lying down in a very awkward position, going to develop contractures. Nice splints should be given. That has to be given to the patient to prevent, especially in the food, if the patient is developing equine deformity. The patient will not be able to stand or to sit properly. Such devices have to be given at night also while they are sleeping. Then seat for breathing. Seat for breathing, I mean one commode to improve, 3-in-1 commode to improve self-control. What is 3-in-1 commode? They give a seat that the patient is sitting. The seat is removed. They wait on the same wheelchair. You remove another seat and you can do potty in that. This is removable below that. Such a chair I had made in my rehabilitation center, where a mother was taking her child, huge size of a child, nobody could help, and she had to take the patient to the bathroom, this and that. So a wheelchair has all this. I'm sorry I couldn't see the picture. She never told me. Anyway, but I'm explaining. It's a wheelchair where the patient can sit in this position, lie down, sit properly, enjoy the TV and everything at home, and you can remove one seat from below, you can aid the person, you can remove the seat, the potty can be easily removed from outside. Nothing is necessary for
Now, mobility devices like walker. The walker can be given a seat to sit. If the patient is that type of a person who can walk with a walker, then a seat is given behind so that whenever she stands, the person sits, does not fall. Alright? Then there are so many types of wheelchairs. My own son-in-law is a polio patient, married to my blind daughter, who is assistant government leader for 25 criminal court and high court in Nagpur. Now, he has got three types of wheelchair. We teach the patient the wheelchair can be, the parts can be removed. Alright? And so we teach the patient to shift from the cot to the wheelchair, to the bathroom. Home adaptations are given. A patient had come who said that his wheelchair does not cross the door, which is too narrow, and I cannot reach the bathroom. What we did was took out the wheel and put it under his wheel, his chair, and he could go into the bathroom. So such home devices are also done with the wheelchair where the patient. We teach them shifting. Alright, from one place to another, all wheelchair parts can be removed. Just 10 years before, my own son-in-law, my granddaughter, myself, with another guy, we have traveled and to Goa for my son and my grandson's wedding. No problem. Everything. Alright, and it's got different types of wheelchair, heavy wheelchair, then the smaller wheelchair, a foldable wheelchair, a removable wheelchair. We have all these types of wheelchairs. So that also can be given to the patient. Alright, and it is all available in Nagpur also and other places also. You can find out from them.
Ma'am, actually, we are
just दो लाइन तीन लाइन दो लाइन बच गए. Then importantly, energy saving devices have to be used. One important thing which I have noticed is the family always in India, they tell such a patient who is disabled, too bad, हम करते हैं. That is wrong. Either the grandfather अपना नाम डालता है, मतलब grandmother, अरे मत बोलो बच्चे को नहीं कर सकता. No, that is not important. The person has to do everything by energy conservation. Occupationally does it in a different way, whatever the person wants. And there are so many devices which are selling in the market. My daughter cooks in she has been given a device where जो बर्तन है वो गर्म नहीं होगा, so she cooks on that. And then, so such devices are also make the person do everything. Finally, the frail patient, the poor quality patient who is hospitalized, they require interdisciplinary care which requires a nephrologist, the physicist, the geriatrist, team of occupational therapy, physiotherapy, nurses, and social workers. If the patient is admitted, a team has to be made, and everybody they have their method of helping a patient. So this is giving me a pleasure that I have been given at least 5 years.
Dr. Nikhil Professor is a consultant nephrologist at 7th Hospital and IGPMC Nagpur. Dr. Vasant Professor is a retired occupational therapist. He has been actively involved in professional body and curricular development, helping strengthen body education and services in India. He is a living example that true passion for the profession never retires. Dr. Maharaj is requested to welcome Dr. Nikhil and Dr. Vasant to the session. Chairperson, over to you. Please invite our next speaker, Dr. Teresa.
Good morning, everyone. We have been to share last session of today's program. For the final talk, we have for interesting topic, population in oncology. Include modalities of treatment. There are a number of cancers nowadays. Considering our focus of care, controlling the disease to improve the rehabilitation in renal cancer survivors also. So for that purpose, we have Dr. Government Medical College Nagpur and has received training in rehabilitation from RTMNU Hospital, Mumbai. She is currently head of Department of Cancer Rehabilitation, National Cancer Institute, Nagpur. She is pioneer in establishing the first cancer rehabilitation services in Central India. She has over 30 years of experience in oncology rehabilitation and has treated more than 30,000 cancer patients. Her expertise includes integrated cancer rehabilitation, radiology and pediatric oncology rehabilitation, and advanced rehabilitation planning for newly diagnosed cancer patients. She is also actively involved in research programs which include oral dysbiosis in cancer patients, nutritional assessment in cancer patients. So I request Dr. Patel to share her experience in rehabilitation.
Thank you, sir. Good afternoon, respected teachers, colleagues, and my dear friends. Thank you, organizers, for inviting me for this novel symposium. My area of work is mainly in cancer rehabilitation. So today I will speak about the rehabilitation in kidney cancer patients. Next slide, please. Before I speak specific to kidney cancer, I want to elaborate what we do or what we practice in cancer rehabilitation. There is a paradigm shift in cancer rehabilitation. Previously, it was impairment driven. That is, we used to see the patient when the impairments were developed. But nowadays, the model has shifted to prospective surveillance and advanced care planning. Right from the day one, we assess the patient. We identify their risks, predict the impairment, and plan accordingly throughout their cancer journey and support them. Next slide. So rehabilitation is not a single model. It is an integrated rehab. We manage the symptom burden which arises from the treatment, from the disease of patients who have already underlying cancer fatigue. So we plan restorative and recovery therapies, managing by improving the cardiorespiratory fitness, fatigue, assessing their job, counseling, adapting to their lifestyle, giving some targeted exercises, prospective surveillance, giving support in the form of nutrition and psychological. So rehabilitation is a multimodal cancer rehabilitation for kidney cancer patients. Next slide. So what we do? Right from the cancer diagnosis, we assess the patient, we plan for the treatment, identify the impairment, make the patient fit, and make the patient ready for the treatment that is called pre-rehabilitation. During the treatment, we maintain the function that is called maintenance rehabilitation. After the completion of treatment, we restore the function, help the patient to get back to their normal life, that is called restorative rehabilitation. And during the survivorship or the end of the treatment, we again reassess, periodic reassessment is done. Nowadays, next slide, there is a concept of survivorship. Many patients are able to complete the treatment, they are cured, they are cancer progression free, but some unique problems they may face due to the drug toxicities, or if they were young when they were diagnosed, adapting to the normal lifestyle, adapting to the job. So this is called the survivorship. Here, rehabilitation plays an important role. Next slide. So I would like to begin with a clinical case. 61-year-old female. She was diagnosed in 2001, right renal cell carcinoma. She underwent right nephrectomy. No treatment were taken. In August 24, she developed pathological fracture of right femur. Surgical fixation was done. Biopsy from that side was proven to be metastatic renal cell carcinoma. Again, she didn't look any treatment. In November 25, she came with low back pain and lower limb weakness. PET scan was done, which show extensive lung, skeletal, and soft tissue damage. Her paraspinal and prevertebral, and there was a huge renal mass program. Biopsy again was taken from that side. It was again proven metastatic renal cell carcinoma on ISC. Next slide, please. So her performance status was declined. She had pain in the back. She was wearing LS belt. Her lower limb grade was 2. In addition to that, she was anemic and low in nutrition. From this cancer point of treatment, she was planned palliative radiation, some immune checkpoint inhibitors, and CPR. Rehabilitation, our main concern was pain control, limb position, giving spinal support, assessing for mobility, supporting for adaptation for the behavior, not to mention quality of life, supporting for the nutrition, and also what would be the drug toxicities. So, what we have is existing of physical and functional interventions and periodic assessments were done. We navigate or move the treatment to make our faith to go to the goal setting on the quality of life and survival. So, what we do, we objectively measure. Here also we use objective measurements like in rehabilitation. We take the help of pain scales, quality of life scales, SGS scales, Hutchinson scales, neurological scales, cancer specific scales. So this helps us to know whether our interventions are working or not. What are the outcome measures? Next slide. Kidney cancer is incidentally diagnosed in stage 1 and stage 2. Survival is directly linked to the stage. Unfortunately, kidney cancer is diagnosed in late stage. So there is a high burden of care and thus reflecting the high burden on rehab aspect. Next slide. Incidence wise of all cancer, kidney cancer is 1.2%. But unfortunately, as it is like diagnosed in late stage, the mortality rate is high, that is 80%. But however, with newer therapies, the life improvement of the survival rate is increasing. Next slide. So the kidney patient, patients are asymptomatic. They have painless hematuria. They may be having a large abdominal mass. They may be having the lung distress, having lung metastasis, or maybe having pain, fracture, having skeletal metastasis, or having some neurological impairment, having brain metastasis. Some unique site would be parotid, leading to facial palsy, and in addition, they may be having pain, cachexia, or dyspnea. So what we do? We manage their symptom control, prevent further functional impairment, assess the activities of daily living. If the patient is doing job, unable for the job adaptation, make the patient fit and functional for the treatment, improve his cardiorespiratory fitness, plan for the quality of life, and also tracking and predicting his further impairment. Next slide. So kidney cancer patients from the rehab point of view, these patients even in the stage 4 are surviving. Multiple drug estimates, they are undergoing number of line of therapies. And what we see, patients with localized disease to the widespread metastasis. So, and majority of patients are undergoing nephrectomy or mastectomy. So major surgeries are going even in the stage 4. Kidney cancer drugs are unique. They have unique toxicity, thus hampering their quality of life and physical and functional impairment. So, as these patients are adult and older patients, so they may be having existing comorbid conditions, so thus reflecting high burden on palliation and thus having high burden on rehab. So, evidently always research is going on targeted therapies. Many patients are on the clinical trials, and from Indian point of view, kidney cancer is acute, subacute, chronic, and with major surgery. Next slide. So, what are the common cancer impairment characteristics of kidney cancer? Patients who are undergoing nephrectomy, they may be having peri-operative rehabilitation as any cancer which undergoes surgery. They may be having metastasis to the bone, so we have to assess their pain, fracture, or mobility restriction. Lung metastasis may be having dyspnea, liver, brain, some neurological impairment. From the drugs point, next slide, drugs point of view, they undergo immune checkpoint inhibitors. They are known to produce the endocrine dysfunction, pneumonitis, other effects on the muscle, joints, skin, colon, thus underlying the need of rehab. And tyrosine kinase inhibitors, they produce Ashwini syndrome, leukocytis, pain, hypothyroidism, fatigue. They are also the rehab is highlighted. In advanced metastatic disease and with widespread impairment, the aspect remains same in any advanced cancer. They may be having, and these patients need repeated hospitalization. Quality of life aspect remains same in any advanced cancer patient. Next slide. So, what are the layers of impairment in kidney cancer? The first layer could be the age. As these are diagnosed in advanced stage, they may be having the muscle and peripheral nerve changes. Second layer could be the coexisting comorbidity like diabetes mellitus and its complications. Third would be the pre-existing condition like peripheral neuropathy, and not to forget fourth and fifth layer cancer characteristics and the cancer treatment related toxicity. These all impairments need a complex rehab needs. So by assessing, by objectively assessing and then planning for the treatment. Next slide. So what we do, the prospective surveillance model for functions in any cancer apply to the kidney cancer also. Right from the diagnosis, when the medical work is done, we, on the baseline only, we assess their function, whether they are having comorbidity, and introduce the function of pre-rehabilitation. When the treatment is initiated or the plan of treatment in the 1 month, we again assess their function, introduce the rehabilitation services. As the patient undergo multiple line of therapies, like in the form of surgery, radiation, or chemotherapy, we again assess the function, anticipate the side effects, and introduce rehabilitation program of as needed. In the survivorship or after the completion of the treatment, follow-up planning is done, and in the survivorship, we monitor if there are any late or late effects, and rehabilitation introduction is needed whenever it is needed introduced. Next slide, please. So again, Wilms tumor. It is found in the adolescent age. So the problem arises. The problem may be the both physical, mental, scoliotic. The patient may be having anemia or hypertensive, or they may be facing malnutrition. Treatment involves surgery, radiation, chemotherapy. They may be having some infection or neuropathy, learning disability, memory. In addition to that, socio-economic impact and associated congenital anomalies. Next slide, please. So, is there any evidence that rehabilitation helps in kidney cancer patients? There was this recent study identifying the need of pre-rehabilitation in cancer patients undergoing nephrectomy or nephrourectomy. What was found? More than 50%, there were two groups. 62 patients were assessed, and they were divided into two groups who underwent nephrectomy or nephrourectomy. More than 50% were found to be nutritionally compromised. More than they have a high BMI, thus having high obesity. Next slide. Many patients were on polypharmacy, that is they were taking many drugs. Frailty score was low, and also nutritionally compromised. So what was to be found? That all these pictures of the patient pictures show us the need of, next slide, pre-rehabilitation, and they were object accessibly by 6-minute walk test and 30 sit-to stand. And what was found? That all these patients, more than 50%, their performance decline was already declined. Performance status was already declined before the surgery. It further declined during the discharge, and gradually it started increasing. Next slide. And in the 30 sit-to-stand, only 40 to 50% patients were able to complete 20 sit-up stands of the sitting position. Here also the performance status before surgery was already compromised. It got further declined, and then it gradually started to improve. So the conclusion was the study demonstrated substantial post-operative decline in functional status in patients undergoing nephrectomy or nephrourectomy. Early rehabilitation or early rehabilitation helps to improve the outcome measures. Another study was there, enhanced recovery after surgery. Here also it was found that the optimal rehab and cost of nephrectomy, when peri-rehab program was introduced, it got improved. It got improved. The second study was, next slide, assessing barriers and facilitators to return to work for kidney cancer survivors. It was a 6-month longitudinal study. Patients were assessed in first month, third month, and 6th month who underwent nephrectomy or nephrourectomy. And what they found out and what were the barriers. Next slide. Patients who had higher efficacy, they returned to work early. Their recovery was fast, and there was also they were more effective to return to work. Given them the psychological support and tailored rehabilitation program helps them for recovery and early return to work. Other barriers were high anxiety levels, low self-efficacy, older age, high post-operative fatigue, physical demanding jobs. So, by seeing this, what there is a need for the structured rehab program. Structured rehab program for an individual help us early return to work. And early return to work is a major outcome in cancer rehabilitation. Next slide. So, cancer rehabilitation teams here in the National Cancer Institute, we better called it the cancer adaptation team. This is short about the kidney cancer. Thank you.
Thank you, Dr. Pandya, for a very good presentation. Today, in this symposium, we learned a lot about the rehabilitation of renal cancer patients, where the goals of physiotherapy and occupational therapy are slightly overlapping, but they play a very distinctive role in the rehabilitation of cancer patients. Thank you very much.
Thank you, ma'am, for this insightful presentation. I think rehabilitation program should be a part of management of CKD patients also, and it should also be included in the management of renal oncology care also. And early institution of rehabilitation program can definitely improve the functionality of the patient and even the treatment tolerance and quality of life will also be better for the early institution of rehabilitation.
We request chairperson to present the summary to Dr. Teresa. Thank you once again to all our dignitaries, faculty, speakers, and educators. Let's just together build a healthier tomorrow through movement and rehabilitation. To conclude this wonderful session, I request Dr. Amar Dukane sir to propose note of thanks.
Society and all the organizing people. I would express to all who came today, contributed directly or indirectly for the successful conduction of this renal rehabilitation study, unique kind of solution which blend around different specialties and bring together occupational therapies, physiotherapies, people from PG department, nephrologists. So this is a unique kind of program. I express my heartfelt thanks to all the speakers who have given a wonderful talk and their insightful lectures taught us different aspects of actually renal rehabilitation. It should be included in the and it is a multidisciplinary thing, it's not about one specialty, it's more different people, different kinds of skills, and we learned a lot from their also thank to their persons who has guided these sessions very well and theoretical analysis and communication sessions and the practical things I would like to express my personal thanks to Dr. Rashtrasant for PG Department of Education for constant and unwavering support for this program. Thank you, ma'am, for this collaboration and providing this venue and logistics. And I also wanted to thank your PG department, Mr. Kilesh and all Danish and all the persons of the department they are continuously working for the successful of this program and with all designing they have done and very meticulous, particularly things have been done and they are working day and night for this program. Thank you, special thanks to them. I would like to special thanks to Dr. Dhananjay Professor and Ashwini ma'am, who are the brain behind this concept and initiating and shaping this important idea and making this happen. Thank you, sir, and thank you each and every member of the Ashwini Clinical Center. Thank you very much. I also extend my sincere thanks to Dr. Piyush Kumar, our President of the Nephrology Society, for his leadership and constant support. I took this opportunity to also thank our OCs, Shweta Amit and Pooja Mahore, for wonderfully conducting these sessions, and also I request Ashwini ma'am to please give the vote of thanks. And thanks all the participants, all the delegates who enthusiastically came today Sunday morning and make this program successful. And, thank you very much. And I was thank you for this program. Please remember to fill that form. So that your certificate can be generated from there. This one. Postcase and feedback form both will be saved.
Yeah, we are changing one QR code for the feedback because the certificate will be based on the feedback only. So you have to fill the feedback form systematically, whatever type of name, institution name you want, because everything will be based on the feedback form. And another thing we have given to one test, so we just request you to reappear for the test. That will be great help for us to make the process more meticulous, more systematic. Thank you.
Thank you.
At least this QR code is for
Feedback.
feedback form. So just Google Lenses QR code to please scan the link. Then only you will be able to get that.